Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Pat Anderson, editor of MIMS Learning, and I'm here with another medical editor from our team.
Hello, I'm Sangeeta Krishnan.
Today's topic is autoimmune disease, which is surprisingly common. According to a study published in The Lancet in 2023 of 22 million UK residents, and of them, nearly 1 million had a new diagnosis of at least one autoimmune disease between 2000 and 2019. A total of 19 common autoimmune disorders were studied in this research, and it concluded that these disorders affect 10% of the population.
10%? That's a big chunk of the population.
Yeah, absolutely, and higher than I would have thought. So, Sangeeta, can you guess what the difference was in prevalence between women and men?
Thinking of just the cases I know, autoimmune tends to be higher in women, so I would guess there's a significantly higher prevalence in women.
Yeah, that's correct. It's actually, according to this Lancet study, 13% of women and 7.5% of men. So women are definitely more affected. And individuals may have more than one autoimmune disease at the same time, according to the study.
So thinking back to my immunology lectures from my postgrad, which was quite a while ago, I can see why that would be. The same factors like genetics and environmental triggers are involved in autoimmune disease, so logically follows that having one autoimmune condition would mean a person is vulnerable to developing others as well.
So in this episode, we're going to discuss some of the more common types of autoimmune disease which are covered by our learning materials. We'll provide tips on symptoms, diagnosis and management.
So what are we going to talk about?
I thought we should cover type 1 diabetes, rheumatoid arthritis and psoriasis, as they're all quite common. There's another disorder that the Lancet study highlighted as being diagnosed more frequently, and that's celiac disease, so we'll talk about that. And finally, as it's something you might see as a GP, we'll talk a bit about bullous pemphigoid. Plenty to get through, so let's get to it. First of all, turning to type 1 diabetes. This is a condition that may be diagnosed in childhood or adolescence, and Dr. Laura Wade has written a learning module about its diagnosis in children and young people. Sadly, the UK has one of the highest rates of type 1 diabetes in the world, with an annual incidence in children aged under 16 of 31 cases per 100,000. And incidence is rising by approximately 4% a year. As we know, it's an autoimmune condition whereby the body starts to produce antibodies against the beta cells in the pancreas, and these are responsible for producing insulin, of course. So, what are the symptoms that GPs should be looking out for in children?
According to the learning module, there are 4 key symptoms, the 4 T's, to look out for. These are tiredness, thirst to denote polydipsia, toilet to denote polyuria, and thinness referring to weight loss. There may be other symptoms, of course, and these include abdominal pain, rapid or deep breathing, recurrent urinary tract infections, vomiting, and sweet or fruity smelling breath. But by the time a child starts showing symptoms, around 90% of beta cell function may already have been lost. So Dr. Wade says that same-day referral to pediatric services is required for a child showing symptoms to prevent diabetic ketoacidosis.
Yes, and once diagnosed, it's recognised that the burden on children and their carers will be immense. So a lot of information and support is needed. This includes the basics of diabetes management, how to interpret blood glucose measurements, how to adjust insulin doses, and the importance of preventing long-term complications of diabetes. NICE recommends that children with type 1 diabetes should get real-time continuous glucose monitoring, as this is associated with better time in range than flash monitoring or finger prick testing, and insulin pump technology is also widely used. We have lots more learning around type 1 diabetes, and as it affects adults as well as children. And this dives more deeply into the recommendations of NICE around continuous glucose monitoring, the use of hybrid closed-loop systems, and most recently we published a case-based audio module discussing the management of hypoglycemia. Just one further thing to mention before we move on. Dr. Wade says that in type 1 diabetes in children, screening for celiac disease is recommended at diagnosis. And this ties in with the Lancet study's finding that a diagnosis of type 1 diabetes in childhood is associated with significantly higher rates of Addison's disease, celiac disease, and thyroid disease. So that's something to bear in mind when you're seeing your younger patients with type 1 diabetes. We'll talk more about celiac disease in a few minutes, but what's next on the agenda, Sangeeta?
So next we're going to look at rheumatoid arthritis. The numbers here are different, as rheumatoid arthritis is the most common inflammatory joint disease in the UK, and about 20,000 people are diagnosed with it each year. The age profile is very different, as it tends to present in people aged between 50 and 70 years of age. Rheumatoid arthritis is a systemic disease, and it affects more than just the joints, tendons, and ligaments. According to a clinical review by Professor Rod Hughes, it's vital to diagnose rheumatoid arthritis early and to start disease-modifying anti-rheumatic drugs, or DMARDs, as early as possible.
There's a window of opportunity, isn't there, for preventing damage?
Yeah. So in the module, it says it's important to start DMARDs within 3 months of disease onset in order to reduce symptoms, prevent damage, and minimize other risks like osteoporosis and cardiovascular disease. The module says that although the American Rheumatism Association criteria are used to classify the severity of the condition, they shouldn't be used for diagnosis. By the time they meet the ARA criteria, patients may have developed irreversible deformities, especially in the hand joints, such as boutonniere, swan neck, and Z-thumb deformities. The module says that many rheumatology departments have early arthritis clinics that can help with urgent referral. So, Professor Hughes recommends having a high index of suspicion and referring urgently if patients have any of the following. First, persistent pain or inflammation in the small joints of the hands or feet, lasting for more than 6 weeks. Second, pain or inflammation in more than one joint. And third, early morning stiffness in joints, lasting more than 30 minutes.
So just to clarify, you'd refer urgently if there's any one of those, is that right?
That's right, any one and not a combination. And though elevated inflammatory markers like CRP and ESR are usually found in RA, these markers may be normal in some people, especially early on in the disease. Rheumatoid factor and anti-citrulline antibodies such as anti-CCP are found in only 50 to 60% of confirmed RA cases during the initial presentation. So a key message in this module is that negative serological tests or X-ray findings should not deter you from referral if the history is suggestive of inflammatory joint disease.
Oh, okay, that's a good message to pass on.
Yes, and the module also goes on to discuss management of rheumatoid arthritis, including the use of conventional DMARDs and biologics. And it stresses the importance of the associated increased cardiovascular risk, which needs to be managed. So do have a read if you want to update yourself on the management of this condition.
Absolutely. And when we interviewed consultant rheumatologist Dr. Tamir Mali some time ago on this podcast on the topic of rheumatoid arthritis, he said it's a field where newer treatments and increased eligibility for those treatments is going to reap rewards in terms of remission from the disease. So let's hope that the prognosis for patients with this condition will be changing in the near future. Next up, and somewhat related to the topic of arthritis, we're going to talk briefly about psoriasis. This is a common, inflammatory, relapsing and remitting condition characterised by well-defined dull red plaques with silvery scales localised on extensor surfaces and the scalp. It affects around 2% of the UK population, with first-degree relatives of affected individuals having a 10-fold higher risk of developing psoriasis. I'm getting these figures from a clinical review by Dr. Claire Marshall and Dr. Anshu Sahota, updated by Dr. Suchitra Chintapalli. And here's where the joint aspect comes in. The prevalence of inflammatory arthritis in patients with psoriasis is estimated at up to 30%. Psoriatic arthritis can mimic osteoarthritis, rheumatoid arthritis, and ankylosing spondylitis. And it can sometimes just involve one large joint.
That's interesting. So in terms of presentations of psoriasis, what are GPs more likely to see?
So they might see a typical psoriatic lesion, which is a well-demarcated erythematous plaque covered with white silvery scales, usually symmetrically distributed, typically over the extensor surfaces of the limbs as well as the trunk and scalp. And this plaque type, also known as psoriasis vulgaris, accounts for 80 to 90% of cases. However, the first episode of psoriasis that a patient experiences could be guttate psoriasis, and this could be triggered by a streptococcal throat infection. Guttate psoriasis involves numerous plaques, all looking the same, with a diameter of less than 1 centimetre. And this episode might be followed by episodes of vulgaris type psoriasis. Less commonly, according to Doctors Marshall and Sahota, psoriasis may occur only in body folds such as the axillae, groin and umbilicus. This is called flexural psoriasis and tends to be shiny and red and less scaly.
And are there any other kinds of psoriasis?
Yes, apparently so. You might see palmoplantar psoriasis affecting the palms of the hand and soles of the feet, or rarely you might see widespread psoriasis known as erythrodermic psoriasis when over 90% of the body is affected.
Oh, and that sounds serious.
Yes, it is, and hospital admission may be required. So for tips on management, do visit the learning module on psoriasis. And for now, let's move on to celiac disease.
So we have a clinical review on celiac disease by Dr. Mohammad Shiha and Professor David Sanders. I have a question. What's the connection between celiac disease and an iceberg?
Don't know. Penguins allergic to gluten?
No, that's not it. The connection is that in spite of rising incidence and awareness, patients diagnosed with celiac disease are only thought to be tip of the iceberg, with many more yet to be diagnosed.
Okay, so it sounds like GPs need to be aware of the possible presentations then. What should they be looking out for?
As we know, celiac disease is a common autoimmune enteropathy triggered by ingestion of gluten. It's now recognized that it can occur at any age and not just in childhood, with various symptoms ranging from the classical symptoms of diarrhea, weight loss, and failure to thrive to other manifestations such as anemia, fatigue, and ataxia. NICE recommends testing for celiac disease in a variety of scenarios, and there's a useful table in the module that mentions these. Just some examples are faltering growth, prolonged fatigue, severe or persistent mouth ulcers, unexplained vitamin deficiency, and IBS. So perhaps for the GP, it's worth considering a celiac test for patients who are coming back with these symptoms, just to exclude celiac from the differentials.
Yes, presumably a lot of the symptoms mentioned in this table overlap with other conditions. But as I understand it, serological screening has a high sensitivity, so could be really useful to rule out celiac disease.
It is widely known that the only treatment for celiac disease is a lifelong, strict, gluten-free diet. This can be difficult to follow, and up to 20% of patients may have persistent or recurrent symptoms despite a gluten-free diet. According to the authors of this module, the most common cause of these symptoms is inadvertent exposure to gluten. So dietitian support might be required, and those who still have symptoms after excluding gluten exposure should be referred to a specialist center.
Yes, as with other chronic diseases, constant adherence to a regimen for the rest of your life is a real challenge. So finally, just to squeeze one more thing in before we go, let's talk about an autoimmune cause of skin blistering. Blistering is a common presentation and may have many causes, but bullous pemphigoid is evidently the most common autoimmune blistering condition in developed countries.
What should GPs be looking out for to identify this condition?
Well, it primarily affects people over 70 with non-scarring subdermal bullae developing. And these may be tense and may have the full thickness of the epidermis as their roof. This is different to pemphigus vulgaris, where the bullae are fragile and easily ruptured. There are multiple risk factors, including medications and neurological disorders, and patients may present with a history of a variably intense pruritus for months or years before developing blistering. Medications implicated include gliptins, loop diuretics, immune checkpoint inhibitors, and penicillins.
Yes, I have heard about the role of immune checkpoint inhibitors in bullous pemphigoid, so it's important to consider this when treating patients who've had a past cancer diagnosis and have had immune checkpoint inhibitors in the past for their cancer.
Yeah, and a clinical review of this condition by Dr. James Powell lists a set of differential diagnoses, but acknowledges that differentiating between immunobullous disorders can be impossible at initial presentation.
That sounds a bit tricky.
Yes, so there may be limits to what the GP can do, and referral obviously may be required, but Dr. Powell points out that it's worth considering bullous pemphigoid in any elderly patient who presents with pruritus of an uncertain cause. Management options include steroids and antibiotics, and the disease usually remits within 5 years. So it's worth having a look at this clinical review if you're interested in dermatology and would like to know more. So what have we learned today? First, suspected type 1 diabetes in a child should be dealt with urgently. By the time a child starts showing symptoms, around 90% of beta cell function may have been lost. So think of the 4 T's: tiredness, thirst, toilet and thinness as a useful mnemonic. Secondly, there's a similar message around suspected rheumatoid arthritis. Don't delay referral if key symptoms are present. Negative serological tests or X-ray findings should not deter you from referral if the history is suggestive of inflammatory joint disease. Third, GPs should perhaps think coeliac disease in patients with a wider variety of symptoms than the classic ones of diarrhoea and weight loss. Could that child with faltering growth, or that person with prolonged fatigue, severe or persistent mouth ulcers, unexplained vitamin deficiency or IBS actually have coeliac disease? So thanks for joining me for this discussion about autoimmune disorders today, Sangeeta.
Thanks, I learned a lot today.
Me too. So don't forget you can claim CPD credits for listening to this podcast, so be sure to go to mimslearning.co.uk to download your certificate and find links to useful resources and further reading. Thanks for listening. We've been the MIMS Learning editorial team, and this episode was produced by Till Owen. Next week, join me as I talk with Dr. Pippin Singh about how to make best use of fit testing in primary care. Don't miss it. It's going to be a good one. We'll see you then.
Think about how your safety net failed fit returns. So if you do get a patient who's not submitted their fit, what safety net do you have in place for that? So do you have an alert from the lab? Because in where I work, the lab actually send us a notification saying the patient's not submitted their fit test.
Oh, do they? Oh, that's interesting.
They do, and I'm not sure, Pat, if that applies to everywhere. So if it doesn't, think about how you manage your non-return fit tests.